Hinduja Hospital, Mumbai also. Presently, he is director of the famous Chaudhary Imaging Centers at Patna and Samastipur. He has numerous papers and presentations to his credit regarding the radiology. If I start introducing him further, it will take the whole session. So because he has so much papers and so much accolades in the field of radiology, that it will take a long time. So I hand over the further proceedings to Dr. Rajan Chaudhary for his class on the chest X-ray. Over to Dr. Rajan Chaudhary, sir.
Okay. I hope I am audible.
Yes, yeah. You're
okay, so I start sharing my slide. Okay. I think I have to quit and rejoin probably.
There is some technical glitch. So Dr. Rajan Chaudhary.
I think I have to rejoin.
Okay, sir, do it.
Okay, let me rejoin. Because since there is a recording, it says that you must rejoin. Let me see. Am I audible and is my screen visible?
Yes. Screen is also visible and you are audible.
Okay. It needed permission for me to allow recording, so I had to rejoin. Okay, so today is going to be it's not a talk, it's going to be more like a casual sharing of information. And it's been a long journey that we have had. And of course, Dr. Kamlesh Tiwari is a very renowned physician, and I have known him since I came to Patna. Dr. Sanjay has also been a very close friend, so it is good to be amongst friends. Now, before we jump into the session, I'll deal with a little bit of history. So, two of the very epoch-making or very important milestones have been the Nobel Prizes for discovery of X-ray way back in 1901, and then for the discovery or the invention of the CT scan in 1979. But today we are going to deal with X-rays. And X-rays have also had a wonderful development in the last 15 years, is that they have been computerized or have gone digital. Now, the big advantage of this digitalized system is not only can we control quality while we are taking the X-ray of the patient, but in case the quality is a little inferior, a little compromised, in the post-processing, we can recover some of the quality. And once we have recovered the quality, we can also send it across the 7 Cs. We can send it to the clinician. We can send it to the hospital. We can give it to the patient in a USB drive or on a DVD or whatever. So this transportability, controlling the quality of acquisition, and if compromised, acquisition to improving the output has been a big advantage. Now, this was developed in 2 phases, all this thing that I have been talking about. The first phase was the advent of computed radiography, which is CR system, which was loosely called the digital radiography, but that was not a digital radiography. Now, in the CR system, all we replaced the dark room. So the machine was the same. Patients had to lie down on the table. The cassette went into the bucky or went inside the table. Instead of the film being inside, there was a screen, a sensor screen. Once the X-ray was taken, this particular cassette with that sensitive screen was put into a reader. The reader took the screen outside, read it, and after having read the screen, put it on the computer, on the monitor, and at the same time wiped the screen fully so as to be ready for the next acquisition, for the next X-ray. So this was a lot of mechanical work that was going on, but it was very fast. We could do a patient in a couple of minutes. At the same time, but one trade-off was, after we purchased this machine, this looked very fantastic. Initially cost a lot of money, later on became quite cheap. Suddenly we realized that we are irradiating our patients a lot. So suppose we would take a lumbar spine X-ray at 80 kV and 100 MAS or 120 MS. After we purchased the CR system, we were suddenly giving the patient twice or thrice the normal radiation. So this was obviously not acceptable. Next came the true digital radiography system, where there were no cassettes, no screens. There was a sensor within the machine, which took the X-ray, transported that image to the computer without any moving parts, without having you to take out the cassette, and at the same time wiped it so as to take the next one. So this was much faster, and radiation dose, which during the CR system climbed up about 2 to 3 times, suddenly dropped to about 30-40%, and which on the more advanced system now we can take an X-ray at about 10 to 20% of the dose that we used to deliver in the early 2000s or the late 90s. So this was one huge difference that happened with digital radiography. At the same time, there were other good things that also occurred. So in the high-end systems, we could now, besides giving you a wonderful film, besides giving you a transportable image, besides sending that image all across the hospital, across the 7 Cs, and giving it in a digitalized format, we could do some other work which are also very helpful. So let's look at some of these examples. Now, this is an X-ray, and there is an arrow, as you can see at the top of the film. which points to a left upper lobe nodular lesion. Now, from our MBBS days, we know that if we have a nodule in the lung, we pay a lot of attention to the fact whether it is calcified or non-calcified. Because if it is a calcified lesion, it is almost certainly a benign lesion, except for the 3-4 conditions, which is metastasis from osteogenic sarcoma or a chondrosarcoma. Because there is hardly other calcified metastasis. As far as primary malignancy is concerned, it is possible for a large malignancy to kind of occupy the position of a benign calcification. But in this case, that will be eccentric. Okay, let's look at some other example. This is a CA thyroid which has invaded the trachea. And even if let me go to slideshow. Okay, so this is the moment I start. Okay, I seem to lose the ability to use my cursor the moment I don't know why my cursor is not working. Ah, here it comes. Okay, let's take it as it comes. So even if I tell you that this patient has a large lesion, a large nodular lesion in this area, we still have difficulty in delineating it. And even if I point...
The film is not visible.
Sorry?
The film is not visible.
No longer visible?
Mm.
Can you see the screen?
Only the black screen is looking.
Okay. Can you see it now?
Yes, it is visible now.
Okay. I seem to lose the ability to use my cursor. I don't know what happens. Okay. So even if I show you the arrow and show you the lesion, or this being a large nodular lesion from the thyroid, which has infiltrated the trachea, we still have difficulty in why it stopped working. Anyway, it still has difficulty. Continue to share. Why is it? Okay, so I have put an arrow there and we still can't see the lesion nicely. So what we now have developed in the high-end DR systems is we can do a dual energy subtraction image where we can give you a bone and a soft tissue image separately. Luckily, we have this machine for the last about 15 years. So from a standard chest image, which is there, we can give you a bone-only image and a soft tissue-only image. Now, in the soft tissue-only image, the clavicle and the ribs have been taken off, and in the bone-only image, we see only the ribs and the vertebrae. Now, how this helps is look at this parenchyma-only image, which is showing lots of nodules. Maybe the projection is not so good, but it has lots of nodules. But when you look at the bone-only image, only one of those nodules have calcification. So the rest are all soft tissue images because they were seen on the parenchyma only view. And remember that left upper lobe nodular lesion that I showed you, where I said that if we could make out whether this was calcified or not, the moment we took a dual energy, now we can see it very nicely on the bone-only image, telling us that this is a calcified lesion. So it is very easy to make out a lesion as pure soft tissue or having calcification. And this is a big help. Let's look at the thyroidal lesion that I was talking about. So this is the dual energy lesion, and you can see a dual energy image, and you can see that lobulated contour of the soft tissue going into the trachea, which was confirmed on a CT scan. Since my presentation, that slide presentation is not working, so I have to use my navigation. So this will be a little tricky. Now, besides telling you the difference between nodules and calcification, it is a big help in other conditions as well. Some musculoskeletal diseases, and let's look at those examples. So here you have a chest X-ray. Without the slideshow, the entire presentation has fallen. Let me try again. Can you see it now? Can you see it now, Dr. Sanjay?
Yeah. Yes, it is visible.
Okay. So this is these are the other uses of dual energy. So this is a patient where you have a wonderful X-ray and we can't make out any abnormality. I have given you a magnified image and we can't still make out an abnormality. This is bone-only image. And when I do a magnification of the bone-only image, we have picked up a rib fracture. Let's look at some other examples. So picking up a very small pneumothorax has always been challenging, and we have tried a lot of things like taking an expiratory film, etc., seeing them on the light bulb rather than the tube light, etc. But it's always a big challenge. However, with dual energy application, it is very clear. So on a parenchyma only image, we can nicely see the small pneumothorax. The pleural calcification is also very nicely visualized. This is the lesion. This is a patient who had swallowed a needle. That also is very nicely visualized. Now, besides the, क्या कह रहे हो? मेरा एक lecture है, disturb मत करो. Now, besides the chest imaging, this can also be used in the abdomen to differentiate or to take away the overlying bowel density in an IVP. Computer, of course, CAD has come in a big way, and with the advent of AI, we are well aware of it. I'll not dwell on this. Now, another big advantage of using a DR system, an advanced DR system, is we can take large or long length anatomy in one single image. This is of great help in a patient where we are looking at abnormalities that affect the spine, for example, looking at the scoliosis or for deformities in the lower limbs, etc., varus deformity. But this is again of use only in an orthopedic setting. Another advantage of DR system is we can do a tomosynthesis, which is like cutting slices like a CT scan. In good old days, we used to do tomography, which was very tedious and took a long time. But on the modern machines, we can take slices just like a CT. And these are some of the examples where you can see the vascular structure so nicely, as well as the ribs. This is an example in the abdomen where The slices have been taken at the level of the kidney, and we have eliminated the bowel density totally. So this is of great advantage. Another chest X-ray showing you 2 nodules. We do a volume radiography and they are very nicely picked up, confirmed on a CT scan. Now, so again, let's go back to the basics of a chest X-ray. So how do you know that a chest X-ray has been properly taken, properly exposed? We have been taught that we should be just able to see the intervertebral disc spaces in the lower part in midline. Secondly, it should be well inflated, which means the anterior end of the 6th rib should be seen medially. In the axillary line, we should be able to see the 8th rib, and posteriorly, the 10th rib should be visible. If it is more than this, then there is probably hyperinflation. If it is less, it could be loss of lung volume or a poor expiratory film. Now, a chest X-ray only shows us 30% to 40% of the lung parenchyma. It hides about 60 to 70%. And I'm sorry, my cursor is not working, so I'll just have to tell you. So on the right side, we have 3 lobes. On the left side, we have 2 lobes. Right side, we have 2 fissures, a minor fissure or the horizontal fissure and the oblique fissure. On the left, we have the solitary oblique fissure. Now, there is a lot of difference in the projection on the chest PA film as well as on the lateral film. So on a PA film, about upper 50% is what consists the upper lobe. The middle lobe is close to the cardiac border and is triangular or a sail-like structure, and only a small part of the lower lobe is seen independently. Whereas on the lateral film, majority of the posterior 2/3 of the lung shadow consists of the lower lobe. And if you drop a horizontal line, then you can see the middle lobe in that bifurcation, and the rest of it is the upper lobe. So this is what I talked about, the inspiration and the expiration film. Expiration film is wonderful. If we are taking, please excuse the bad spelling. So in the expiration film, is the only use I can think of is possibly to pick up a small pneumothorax or to show you air trapping. Otherwise, inspiration is very important. If you take an expiration film, almost 90% of the patients you would think have an abnormal chest X-ray. Now, and other things that we have to remember is that the vascular structures in the upper lobe are vertical and they are thinner than the lower lobes. If they are thicker than the lower lobes, that means there is upper lobe predominance, probably due to a pulmonary venous hypertension. Both lungs should be symmetrical. They may not have a symmetrical morphology, but they should look symmetrical. Both hila should also be symmetrical. There may be a little change in size, but the density should be same. And the lateral third or the lateral 2 centimeter to 3 centimeter of the lung usually is bereft of any markings. If we pick up markings, lung markings in the lateral third, that means we are dealing possibly with a shunt vascularity. Now, let us see how we can implement. This is going to be a very basic presentation. So for consultants, I don't know whether this is too basic for them. So let us look at the examples that I talked about. On my left side or on the right of the screen, you have a normal chest X-ray, and on the left of the screen, we have a patient with pulmonary edema due to congestive heart failure. And you can see the difference. There is upper lobe predominance of vasculature. The upper lobe vascular structures are much thicker than the lower lobe. There is some degree of, there is some pleural effusion as well. And usually the vessels are very sharply defined on a normal chest X-ray, but on this you can see they are much thicker and the margins are not so clear. And if I give you a magnified view, all these findings become much more clearer. Let us not forget the something that we learned during our MBBS days, the curly B lines, which are nothing but fluid accumulation within the interlobular septa, frequently seen in cases of congestive heart failure. This may also occasionally occur due to infiltration into these interlobular septa in a case of malignancy. Now, the lung has only two responses to disease. It can either become black or it can become white. And it is on the morphology of whether it becomes black or white, we have to make a diagnosis. So reading a chest X-ray can be extremely difficult unless we are looking at the history of the patient and correlating with other clinical findings. So on the right side, if you remember the division of the chest film that I had done, on the right side, we have a fairly homogeneous opacity in the right upper zone with a flat transverse margin, which is the transverse fissure. And we see tubular air densities within it. So this is a classical case of a lobar consolidation, which has affected the right upper lobe. And it also tells us that the bronchus is patent, meaning this is almost certainly a benign cause of consolidation. There are a few exceptions like bronchoalveolar carcinoma and lymphoma, which may be malignant but may have air bronchogram. So this is on the left side is the upper lobe consolidation. On the other side, we have a lesion where the cardiac margin is very nicely seen and the diaphragmatic margin is also fairly well visualized. Therefore, this obviously is not in the upper lobe and has probably involved a part of the lower lobe. Now, after the lobar consolidation, if you look at this X-ray, we find that in this, we do not see that typical homogeneous opacification, but instead, we see a dirty lung where there is peribronchial distribution of opacities, which are also seen in the right upper as well as in the lower zone. And on a CT scan, we can see that this is a bronchoalveolar pneumonia. So they look very different, and the causes are also different. Whereas in this patient, we see both reticular as well as nodular shadows. There is loss of lung volume, especially on the right side. The lung sizes are smaller, and we can pick out a lot of small cystic spaces within the lung fields. A typical pattern of usual interstitial pneumonia with honeycombing and traction bronchiectasis. Now, let us look at some of the common signs that help us tell you which lobe involvement is there. And the famous silhouette sign. On the right side, we have a lady and a gentleman under an umbrella, and they are very close to each other. So we do not see the difference. We do not see any distinction between the man and the woman. And this is the basis of the silhouette sign. So the loss of distinction between the density of the mediastinum and the lung because of occupation of lung by fluid, infiltrate, or whatever. Now, depending upon the distribution of the lobe, we can tell you which lobe is involved. So on these two films represent a consolidation and involvement of the right middle lobe because the right cardiac border is not visible. And when we look at the lateral film, we can see the triangular opacity which is the normal site of the middle lobe. Whereas this, which is I showed an example earlier, where there is a lack of silhouette, that silhouette between the cardiac border and the lung is not lost, although the lung also has a similar opacity, a similar consolidation. And this is called the curtain sign or the lack of silhouette sign. And this is because of the involvement of the lower lobe, because the lower lobe is not abutting the right cardiac border. However, in many a case, we may see that the diaphragmatic border is lost because the lower lobe is in contact with the diaphragmatic border, not in this patient. Now, another famous sign is the golden S sign. Now, in this patient, normally the left diaphragm is situated at a lower level than the right diaphragm because of the heart, which is pushing it down, and because the liver is pushing the right diaphragm up. In this patient, we see that the left diaphragm is elevated and there is tenting of the dome. Now, this is a very important information because the ligament has pulled it up because of the loss of lung volume in the left upper lobe. And the S sign, as seen on the PET CT, has been named after a famous radiologist from US by the name of Golden. So this goes by the golden S sign and is typically seen in malignancy. This is again a very important X-ray. So we see that there is mediastinal shift to the right. The right lung is of normal volume or maybe a little less. The left lung has increased volume and there is lack of normal lung marking in the lower zone, and the mediastinal shift is fairly prominent in this patient. So this is an encysted but a tension pneumothorax and needs to be treated, and the mediastinal shift is a very important finding. So what are the blind spots when you're looking at the chest X-ray, which need to be evaluated very prominently? Now, the blind spots, one I said was look at both the hyla and the apices. These are the two blind spots. Why the apices? Because the apex of the lung is a very busy place. So you have the anterior end of the first rib, the medial end of the clavicle, the posterior part of the first and the second rib, and their articulations with the sternum. So this is a very busy place, and we can easily miss a lesion in the apex of the lung. The hilum is another tricky thing. The right hilum is located a little above the left hilum. They should be of equal density, even if morphologically they look a little different. However, for this, the chest X-ray should be properly centered. And how do we tell that? We look at the spinous process of the vertebra, look at the medial end of the clavicles. The medial end of the clavicle should be equidistant from the midline spinous process. So that is how we tell, because if there is rotation, then the hilar sizes and density will be entirely different, and you will call a normal X-ray abnormal and an abnormal X-ray will be called normal. So we have to be very particular about these. So here the last patient had an intrapulmonary nodule in the right apex, very difficult to pick up, confirmed on CT. So the two blind spots are the apices and the hyla. What are the obscure areas? Or you can say the blind spots again, extended. These are the obscure areas or extended blind spots, the retrocardiac region. So left lower lobe collapse will hide behind the cardiac density. The subdiaphragmatic area, you have to remember that the diaphragm that we see, the lung posteriorly extends much below the diaphragmatic line or the contour that we are seeing. On the lateral view, the lung that overlaps the vertebral, the dorsal vertebrae. Important thing to remember is as you go down the dorsal vertebrae, the lucency of the dorsal vertebrae should increase. Why? Because the lung occupies a much larger volume inferiorly than at the apices. At the apices, the lung has a very small volume. At the base, it is very large. Therefore, the dorsal vertebrae should be much blacker as you go down the dorsal vertebrae. Another place that you can miss abnormality is a retrosternal area. So if you have a large retrosternal lucency, you're dealing with an emphysema. Or if you have some density and the retrosternal lucency is lost, then you're dealing with an anterior mediastinal mass. And again, the part of the lung that overlaps the cardiac shadow. Other parts which may be missed are the subdiaphragmatic area where you could miss a renal stone or some other abnormality, and also look at the clavicle and the edges and the visible part of the humerus. So let's look at some of the examples. We have had a lot of theory now. Let's look at some of the examples. So this is a 70-year-old smoker. And the X-rays show some anterior wedging of the mid-upper dorsal vertebrae. And otherwise, apparently they look fairly normal. Since I can't have your response, so there's no use of a quiz. So apparently they look similar. I mean, they look normal. After 9 months, they still don't look very abnormal, but there is a density which is seen on the lateral view. And on the chest PA, the apices of the lungs look asymmetrical, being more dense on the right side and a little lobulated on the right side. Plus the trachea is pulled to the right. 18 months later, they still don't look very abnormal on the chest PA, but on the lateral view now, the density is fairly conspicuous. And this was the large lesion. So chest X-rays in many a patient can really fool you unless you have the proper history and you are comparing both the sides. Now, these two X-rays are only the difference between these two X-rays. They belong to the same person, but there's an 8-month gap. So apparently, if you just had the 8-month recent X-ray, which was taken 8 months later, maybe you would say that, okay, the right cardiac border is a little shifted to the right and the right diaphragm is not so well visualized. But even if you look at the older X-ray, which was taken 8 months earlier, which looked apparently normal, but if you compare the pulmonary hilum, you get the answer. The right pulmonary hilum, although not much larger than the left, but the density is much more. So in this case, an X-ray taken 8 months earlier only had an increased density of the right pulmonary hilum. Later on, after 8 months, you see the right lower lobe collapse. And this is the CT scan that shows the nodular lesion. I don't know why I can't get. Let me see if I can pick up an arrow or something. Because otherwise. Okay. So this is the lesion which is obstructing the right lower lobe bronchus, and you see the atelectatic lung without air bronchogram, filled with mucus. So the nodular, the mass, right infrahilar mass that was missed. Why is the slide not going forward? My screen is frozen. No, guys. Okay, it's working again. Thank God. Okay, so let's look at some of the mediastinal examples. So mediastinum is the part of the chest that lies between the pleura or the two lung fields. And on the chest X-ray, we just have a few lines to go by. So this I have outlined. That's where we expect the right atrium to be, and then the margin of the superior vena cava and the ascending aorta as it turns around and forms the aortic arch on the left side. And then we have the pulmonary artery, the pulmonary bay, and the left ventricle, and the diaphragms below it. Now, the mediastinum also has a lot of stripes and lines which are important. Of the ones that we need to remember is the paratracheal stripe, which is formed by the right margin of the trachea, and the paracaval line close to it on the right side, as well as inferiorly formed by the infravena cava. The paraspinal line, which frequently is extremely important when we are looking for paravertebral abscesses or hematopoiesis, extramedullary hematopoiesis. The para-arterial line along the left subclavian artery. The para-aortic line, again, very important, seeing a lot of undulation or thickening or expansion may be a sign of a thoracic aortic aneurysm. And occasionally we see in the posterior mediastinum a funnel-like shadow in a case of esophageal dilatation, either due to achalasia or a malignancy. Now, a very important concept of mediastinal classification that we need to explain to the clinician, the clinical people who are practicing medicine, is that we consider the mediastinum very differently from what is considered in our textbooks of anatomy. So in anatomy, we had the anterior mediastinum along the anterior margin of the heart and the retrosternal area. The heart was in the middle mediastinum, and whatever was present behind or posterior to the heart was the posterior mediastinum. Now, on a chest X-ray, it is impossible for us to make a difference between the anterior chest PA view. We cannot differentiate between the anterior mediastinum and the middle mediastinum. So, in the famous classification by Felsen, all structures anterior to the posterior border of the pericardium was considered the anterior mediastinum. The middle mediastinum was an arbitrary place, which was a line that was parallel to or curved along the anterior margin, a little posterior to the anterior margin of the dorsal vertebrae, about 2 centimeters behind. And whatever would lie in the paravertebral gutter was the posterior mediastinum. And this was of big help in distinguishing the various etiology. And this is the seminal article, 1969-70, by Felsen. So when we see a lesion on the chest, how can we say whether this is in the mediastinum or in the lung? Of course, characterization on CT and MR is much easier than on chest X-rays. These are the various examples. Let's not go into them. So for a mediastinal lesion, there is no air bronchogram. It will form an obtuse angle with the lung. The mediastinal lines and stripes that I talked about will be disrupted. And since the mediastinum is close to various bony structures, you would see erosion or a destruction of the sternum, vertebra, or ribs. Now, the erosion of ribs could also occur on a superficial lung lesion, which is very classical of a Pancoast tumor or a superior sulcus tumor. But anyway, these help. These are of big help. So this is again typically a lung lesion, homogeneous opacification, air bronchogram, therefore definitely not mediastinal. Now this is what I was talking about. So on my left, we have a parenchymal lesion because the lung is black and the mediastinum is white. So we have a nice interface between the two. And for a parenchymal lesion, if it grows out, this will cause an acute angle at the interface. Now, if it is a mediastinum lesion, which pushes in from outside, at the interface, you'll have an obtuse angle. And this helps. So these are the two examples. That is a large apical mass on the right side. On the left side, you have a superior mediastinal mass lesion with obtuse angles. And on the other side, you see at the margin of the lung, you see the sharp acute angle. This is what I was talking about. Now let's look at some typical mediastinal lesions, which almost give us a histopathological diagnosis. So on the top, we have, okay, again, the cursor doesn't seem to be working. So on the top, we have an anterior mediastinal mass lesion, lobulated margin, moderately enhancing, an invasive thymoma. Left bottom, we have a lesion with a variable HU value, a variable CT density, also having a fat density, which is a benign teratoma. And on the right side, this is a lesion which is in connection with the thymus, has fat density, also confirmed on MR, which is typical of a thymolipoma. Why it's freezes in between. I'll just take a minute because it's got frozen. Okay. Okay. So let's look at some of the examples rather than going into theory. Silhouette sign is something that we talked about. Let's look at some of the other examples. For example, this is a very favorite sign of mine on the chest X-ray, the cervicothoracic sign. Now, in the cervicothoracic sign, you have a large lesion in the superior mediastinum, which is going into the neck. Now, how do you tell this is anterior or posterior? Of course, you can look at the trachea and see if it is displaced or not. And by that contention, you can probably localize it. But a very nice way to say it is that if you can see the margin of the lesion above the clavicle, then this is a posteriorly located lesion. Why? Because the posterior part of the chest and the mediastinum is much higher than the anterior part. The clavicles come anteriorly downwards, and therefore, if the lesion is anteriorly present, it immediately merges with the soft tissues of the neck, and you cannot see it beyond the clavicle. So this is a big help. So the cervicothoracic sign confirms the large tumor there. The thoracoabdominal sign is an extension of the cervicothoracic sign. And you see that lesion on the chest X-ray confirmed on the CT. Let's skip, otherwise it's going to become very long. We'll just look at some of the examples because okay, this is a very interesting case. It's a pediatric patient, showed a mediastinal mass. Now, to tell the truth, it was very difficult to tell you what it was, but you can see the cardiac margin very nicely. Therefore, this is located posteriorly, posterior to the cardiac shadow. The vertebral margins are not so well visualized, so I can't tell you whether there is a vertebral erosion or not. CT, of course, proved it to be a neuroenteric cyst. That you can see the Bogdelic hernia, small Bogdelic hernia on the lateral view by an arrow. So fat, fluid, or how it is enhancing that we have talked about. So this is an 8-year-old boy with a heart murmur. So we see a large anterior mediastinal mass, which is narrowing the trachea, also deviating it to the right. I can't point it out to you because, again, my slides will freeze. Mass does not show any calcification. And on this, very nicely visualized to be a thymic lesion with some calcification is seen on the CT. A teratoma. A 3-year-old boy with an incidentally noted chest mass. The chest X-rays are not projecting so well. Located posteriorly in the right paravertebral region, posterior to the right bronchus, but very close, has fluid density. There is no enhancement after intravenous contrast. Esophagus, which is more medially located. This was proved to be a duplication cyst. An 18-year-old girl with an incidentally noted chest mass. You can see it on the chest PA view. You can see it in the left paravertebral region. It is covered by the cardiac shadow. On the lateral view, you can see it just in front of the, above the diaphragm, in front of the vertebrae. Of course, the CT shows it very nicely, no enhancement. Another case of esophageal duplication. So I've just tried to show you some basic concepts in chest X-rays, how the machines have developed, what new we have been doing for the last 10, 15 years, and what are the basic discipline that we need to observe while interpreting a chest X-ray. Did not try to be very exhaustive and cover everything. Thank you.
So Many thanks for your nice lecture on X-ray, particularly the chest X-ray. So, on behalf of the students, I would like to ask some basic questions from you. That one thing that you have described, which X-ray is properly done or not. That you have told that the intervertebral disc must be visible in the lower parts and all that. So other things that what we should look for, as for example, we must look for the CP angles, we must look for the upper cervical vertebrae or not, or these things, whether the film is to be accepted or the film is to be rejected.
Okay, so I did not go, obviously, if a part of the chest has been cut. I mean, I did not elaborate on that because that obviously is not acceptable. It is like taking a plane from Patna to Delhi and landing at Kanpur. So obviously, all part of the anatomy needs to be covered. It has to be well centered. Therefore, the anterior margins of the clavicle must be equidistant from the vertebral, from the interspinous line. However, this may not hold true in a pediatric age group because what happens in a child is that one of the attendant is holding the shoulders properly, but no one is holding the abdomen and the pelvis. In which case, although the upper part is well centralized, the lower part of the film, the lower part of the chest has become oblique or has rotated. So in a child, you also have to see the medial end of the ribs, whether they are equidistant from the paraspinal line. So this is one. Inflation is very important. We should not and cannot expect, we cannot accept an expiratory film because an expiratory film makes all chest X-rays pathological. Therefore, what I said was we should at least see about 6 ribs anteriorly, medially, 8 ribs in the axillary line, and preferably 10 ribs posteriorly. If we see more than that, then there is hyperinflation. If we see less than that, then compare with the other side. If it is asymmetrical, then there is loss of lung volume. If it is bilaterally symmetrical, if there is loss, then you have to basically talk to your technician, look at the papers and see whether this is bilateral loss of lung volume, or this is an expiratory film. In CT, this is much easier because when we look at the trachea should be a perfect egg-like structure, perfectly round or oval, anteroposteriorly oval. If it is flattened, then this is an expiratory film. So proper inspiration, proper centering, and another there are a lot of problems with improper centering or obliquity. One of the lungs becomes whiter, another lung becomes blacker. The hilum becomes asymmetrical and you'll call it hilar disease. And we should ideally expose a part of the neck as well, and also at least a part of the shoulder joints. And both the scapula must be pushed away. While taking the X-ray, both the scapula in a chest PA film, unless the patient has a fracture or something, they must be pushed away from the lung margin. Now, these are the things that you have to look.
Another thing that I would like to ask, that you have told that the basic advantage of the digital X-ray is the post-acquisition processing.
Correct.
So we may recover something that we are not being able to. So sometime it is not disguising also.
It is. It can disguise. It can disguise. So there is a general tendency. Now, chest X-ray, by definition, should not be very clear. It should be a little unclear. If all the lung margins, if all the vertebrae, if all the ribs are very clearly seen, that means this in the processing, what has been done is that they have increased the contrast on the film. The moment you increase the contrast, you lose the parenchymal definition and you lose the parenchymal information.
So way back, I was hearing a lecture from Dr. Ravi Ramakant, and he told
My
Yeah.
teacher.
He told that always read the digital X-ray with caution. So
A
far, so
lot,
the chest.
lot of this disadvantage is taken care of on a dual energy film, because then
Yeah,
you
yeah.
get a parenchyma differently from the ribs. So that is
And another question that I would like to ask for the benefit of all, that nowadays we are diagnosing a lot of diffuse lung diseases
correct.
like interstitial lung disease and that. And what are the markers of the ILD or diffuse lung diseases in the chest X-ray? Because it is sometimes very confusing, and most of the time we are getting the patients taking the anti-tuberculous drugs for long and long.
Okay. So to tell the truth, if you are suspecting interstitial lung disease, and even if there is a little bit of information, for example, if there is a little bit of loss of lung volume, if the cough is not going away for 2 months or 3 months, if there is some basal haziness, of course, I'm not talking about a florid case that I showed you where there is a lot of increased reticular markings, reticular markings, loss of lung volume, traction deformity of the hyla, or the diaphragm is pulled up. These are all very advanced cases. But even subtle changes of increased density, subtle changes of loss of lung volume, subtle changes causing loss of definition of the margins of the lung, if they match with the clinical picture, rather than trying to second guess the disease, we should go for an HRCT. I would not try and defend chest X-ray in this, and I think if you have sufficient grounds, we should not hold an HRCT advantage from the patient. I would because this is what I do. For example, if a relative of mine comes, or if I have to investigate my wife or my child, frequently, because even on the HRCT we are delivering so little a dose. The low dose is almost just 3 or 4 times a chest X-ray. So we are delivering so low a dose that we should err on the safer side.
Thank you. Another thing that I would like that you have shown one X-ray in which there was a loculated pneumothorax, and you told this is tension pneumothorax. So how we can differentiate between a tension pneumothorax and non-tension pneumothorax?
So by definition, a pneumothorax will occupy a pleural space and will cause some degree of mediastinal shift. But if there is mediastinal shift, then or if there is progressive mediastinal shift into subsequent X-rays or serial X-ray, then besides your clinical information, we should consider it as a tension pneumothorax. So we mainly depend upon the degree of mediastinal shift.
And the old chest X-ray is also very important to compare.
So we have this is again Dr. Ravi Ramakantan's teaching. The world's best radiologist is the old film of the patient.
Yes.
So the best radiologist is the old investigation of the patient, which frequently the patient tries to hide.
Yes.
उसको देख करके diagnosis कर देंगे, वो नहीं देंगे.
Another thing that I would like to know is, can we differentiate a large bulla from a pneumothorax?
On an X-ray, it will be extremely difficult. We can try that on a CT scan. And if we can see the collapsed pleural margin, the pleural margin medial to it, we can make out. A pneumothorax of a similar size will have more mediastinal shift, will have more mass effect. And in the bulla is more rounded, and you should be able to see a thin wall in it.
So some time back I was just going through some articles.
It is difficult, but it is very difficult. I must say.
So bulla has some medial convexity, and the pneumothorax may have some concavity like things, opacity on the medial side. But I was not able
It
to
is very
appreciate
difficult. It is very difficult because many medical colleges and many large hospitals have put a chest tube in a bulla. So
Yeah.
so it is
Yes.
very difficult, I must say. Very difficult.
So these are the basic things that we must learn
These are very basic.
about.
Yes.
Yeah, about the chest X-ray, and more we see and more we interpret, more we become wiser. Uh, so 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 with this comment, I would like to thank Dr. Rajan Chaudhary
Thank you
for
very much.
spending time with us and explaining the how to read a chest X-ray. So many thanks, Dr. Rajan Chaudhary.
Thank you.
So many thanks. We may ask you to take more classes in the future to come for the benefit of students. And I'm also thankful that most of the time you are always ready
I'll be,
to do the academic things. So
I'll,
many thanks again.
I'll be honored.
So with this statement, I would like to stop today's class. So good night to everybody.
Thank you.
Good night.
Thank you.